we are very delighted, and I'm privileged to introduce our Deputy Director of National Institute on Minority Health and Health Disparities, Dr. Monica Webb Hooper, who will provide some opening remarks. Dr. Webb Hooper, please take it away.
Thank you very much, Rina, for that introduction. And I want to welcome everyone. I'm really delighted to be with you and to help open this really important webinar. We know that disparities in hepatitis C are of high interest to NIMHD, particularly intervention research toward reduction and elimination. So I want to offer a few thoughts as we move into the webinar. When we talk about health disparities, they're not just any differences between groups. Key points are that they are by definition preventable or avoidable and are rooted in disadvantage, and they're modifiable. We see racial and ethnic and socioeconomic status as sort of the two pillars of disparities and that drive them, which may intersect with other characteristics such as gender, sexual orientation, geographic location, and other characteristics. Here are the NIH designated US populations that experience health disparities. These groups include all racial and ethnic minoritized groups, socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minoritized groups. Hepatitis C is a viral infection that causes liver inflammation, sometimes leading to severe liver damage. The virus spreads through contaminated blood, and still about 40% of people with hepatitis C virus don't know that they're infected, mainly because they have no symptoms, which can take decades to appear. The development of direct-acting antivirals, or DAAs, which was a huge scientific and medical advancement almost a decade ago, which can cure hepatitis C in more than 95% of infected people. And Hep C liver transplants are down about 50%, which is great progress. Now, medication reach is still an issue. It's more limited than it should be, reaching only a fraction of the people who are infected. And we're still dealing with about 15,000 deaths in the US from hepatitis C complications every year. The virus is spread primarily by contact with blood and blood products. There are a number of risk factors, right? And injection drug use being the most common one currently. That was a difference from the past. I think the point here is that many of the risk factors are preventable, or they have related issues that are preventable, which does present opportunities for prevention and intervention efforts. There are racial disparities in hepatitis C prevalence, with the highest prevalence among American Indian and Alaska Native people and rural communities compared with urban populations. And also we see greater prevalence among females. And when you look over a 20-year period, all racial and ethnic minority populations have had greater mortality rates relative to white persons, which is that blue line toward the bottom of the figure. If you look between 2016 and 2020, the death rates have started to decrease among Latino, Asian, and Pacific Islander and Black persons. Unfortunately, and in contrast, we've not seen this trend among American Indian and Alaska Native persons, as mortality has steadily increased and is about 3 times greater compared with white persons. Chronic hepatitis C associated deaths did increase in 2020 compared to 2019, and were higher among American Indian, Alaska Native, and Black or African American persons compared with white persons. Socioeconomic disparities exist in terms of direct acting antiviral use, with less use among people with lower income levels related to access issues. There's also a higher burden of liver cancer among racial and ethnic minority populations, as well as a lower likelihood of receiving guideline concordant screening for hepatocellular carcinoma among Black or African American patients and patients living in rural locations. So there's a lot of work to be done, and we are pleased to see that attention to what needs to happen for hepatitis C elimination has the attention of the White House, who proposed a 5-year program on this. Also, we're delighted that our program officials at NIMHD recently published a scoping review on this topic, including highlighting opportunities for interventions to reduce disparities. Now, given that the risk factors exist and that many are preventable and that there is highly effective treatment available, it's critical that these advances in screening and treatment benefit all populations. and that prevention is a significant focus. So we encourage investigators to consider multiple factors as they propose health disparities research in this area. This evolving NIMHD research framework that you see here, we think it's an excellent guide for research, and I think of it also as a hypothesis generator. Finally, I want to mention that NIMHD continues to support meritorious research on liver diseases and cancer. We've had a specific funding opportunity since 2017, which is also supported by NCI, the National Cancer Institute, and was reissued in 2020. A new concept on this topic was approved at our February 2023 council. So stay tuned for the release of an upcoming funding opportunity. So I just thank you again, and I'll turn it back over to Dr. Das.